I was always nervous and sort of hesitant about discussions on end of life topics. But today we have a physician and a care provider who are going to share some of their perspective on end of life decisions and planning. And so let me welcome to the stage Dr. Michael Madison and Rosie Gaston, who is a social worker. And we're going to meet them and learn a little bit more about how we can help ourselves and help our families. But Dr. Madison and Rosie, thanks for being with us, number one. And before we dive in to a talk on end of life decisions, let's get to know the two of you. Dr. Madison, if you want to go first, tell us a little bit about your background.
Thank you, Steve. Thanks for having us. I'm a neuroendovascular surgeon. Essentially, I'm a cardiologist for the head. I treat primarily patients with stroke and brain aneurysm. And it was through my interactions with the stroke community that I became most passionate about this topic.
Wow. Okay. And then Rosie, tell us a little bit about your background.
Yeah, thank you so much for having us. I just want to echo what Dr. Madison said. What you're doing with the positive aging community as a social worker, it just gets me excited, and I absolutely love what you're providing, Steve. So thank you. So I have dedicated the last decade of my career to supporting, educating, and advocating for people who live with a life-limiting condition, those that are closest to them, and those that care for them. My journey started out, I went through what they call a quarter life crisis, and it's a real deal. There's a book, there's all those things with it. And I started volunteering for a hospice agency. And I absolutely fell in love with end of life work and just found my calling in that space. Then the following year, I was in a master's of social work program where every project, every paper, every internship, everything I could do was focused on end of life, death and dying, chronic illness, caregiver, grief and loss. And that has never waxed and waned for me in my career since I made that decision. After graduating, I worked in a multitude of settings. I worked in an oncology clinic, inpatient settings, community settings, with specialties in oncology, palliative care, but primarily hospice. Hospice is where I spend a lot of my time. Again, fell in love with the work, found such a need to do more than what I was doing in the clinical setting. So 2 years ago, I founded my own company just to help people become more comfortable talking about and preparing for end of life.
I love it. And okay, some folks are having sound problems. If anybody wants to kind of chime in there, is everybody having a sound problem, or can I, okay, no sound. Sounds good here, nice and clear. Okay, so okay, so it looks like the bulk of folks are hearing it okay. So those folks that are having a sound problem, check your volume. And also, it's just like knocking the TV set on the right-hand side of it. Log in and log out and log in again, because it seems like we've got a few people that have some sound, but for the most part, and I'm hearing it fine too. Okay, little disruption there, but that was a nice little break to chat. And Rosie, I want to kind of before we dive into this, I want to piggyback on what you were saying, because I get some of the same comments is that like I'll have a great discussion like the one we're having today.
Sure.
I'll be like, oh man, today I had this amazing discussion on end of life. And people will look at me like, really, and I imagine like what you were saying is as you were going through your process, and Dr. Madison, you talked about it as well, is that you develop a passion for end of life, and it's just mind-boggling for some people out there. But I think once you're comfortable with talking about this, these become the deepest discussions we can have.
Absolutely. And I also think that there needs to be grace, right? So I hear a lot of end of life kind of thought leaders talking about, the saying of when we get more comfortable talking about death, it actually helps us to live more fully. And while I can't agree with that statement more, you don't start there. This is a process, right? So for a lot of us, when it comes to our beliefs, our comfortability around death and dying and grief and loss, a lot of this is what we were taught as kiddos. Right. So that's what the literature shows. That's what I've seen in my practice as well, too. And that's my living example. I had a mom who was an RN, ICU, ED, cardiology, and we grew up with death being this natural thing that we talked about. And is it sad? Is it hard? Yes, but it's not bad. It's a natural part of our life. And so growing up and hearing that over and over, and then that's why I think when I started volunteering, right away, I was like, there wasn't hesitation. I was comfortable in this space because I think my mom had kind of pre-programmed that a little bit.
Oh yeah, no, that's great. And it's interesting. I've even heard the opposite from healthcare professionals where they don't want to expose their family to end of life. So it was wonderful that your mom set the table for you like that. Okay. Today the two of you are going to sort of share your perspective as providers in the community. Dr. Madison, let me start with you in terms of, what are some of the perspectives that you've gained and tips or advice that you can give to folks from what you've seen in there with your practice?
I think what I've seen, and I think the problem that we have as a nation is that we've allowed ourselves to avoid the responsibility of having these conversations. We all want to live as long as possible. We all don't exactly like thinking about death it seems to be kind of a human condition. And that leads us then to kind of denial and a lack of planning for what is still inevitable. We all are going to die. And what I see on the healthcare side is that the lack of planning leads the endpoint of our lives to be much more difficult and divisive and traumatic than it needs to be. And I feel like that, as you alluded to, Steve, it's like I am very passionate about trying to do better than what we're doing now, because what we see every day in the absence of that is that patients and their families are not ready. And then they almost invariably, there just tends to be a lot of dysfunction that comes forth as a result of that lack of preparation. Notably, they say yes to procedures that aren't medical interventions and procedures that aren't going to make them live longer or better. It's kind of a knee-jerk, just do it. It doesn't, with my stroke patients, that was the classic example. I had, I get called to treat an 88-year-old female who has moderate dementia. She's in a memory care unit. And despite the fact that she's 88 with moderate dementia and a memory care unit, no discussion has taken place, about what she would have wanted if she was able to communicate what she would have wanted. And the family, because of that lack of preparation, I'll say, well, I can go up there and remove the clot. And the best thing that happens is that she's going to go back to the memory care unit and die of dementia. And that's not, there are only a limited number of ways that we die. Among those ways, dementia is arguably one of the least pleasant, because you and your personality leave before your body does, and it's really hard on the family. And so I'll say, the stroke might be a blessing, in some ways. It could short circuit some of that, but they'll end up saying do it anyway. And I've gotten so many calls 6, 8 months, 12 months later saying, Dr. Madison, wish we would have listened to you. Because this is what's happening now is terrible. And I think that my main point is that talk about it ahead of time, plan for it ahead of time, what you want, what you don't want. Do it in a non-emergent setting. Do it when you're not sick and you're not facing a life-threatening surgery that you need to, or some other intervention that you need to take place. Make it clear to your family who you want to make decisions for you in the event that you can't make decisions. I mean, while we're capable to make decisions, we get to make those decisions. That's nobody questions that. While we're capable of making decisions, and some people make good decisions and some people make bad decisions, but they're their decisions to make. The problems really arise when the person no longer can make the decisions for themselves. And under that situation, it needs to be very clear to generally their family members who's going to be their power of attorney, who's going to be their medical decision maker. Is it going to be usually the husband, the wife, or the son or the daughter? It's usually family, but it should be clear who that person is, who that person or persons are. And finally, it should be clear, if possible, give them some direction so that they understand what you would or wouldn't want at end of life. And if you do all that, I'm very confident that patient's end of life experience will be much more positive. They'll die a better, more peaceful and graceful death. Their family will have less divisiveness and destructive, all the destruction that comes along with not doing this ahead of time. They won't have as much pain, and they'll be able to enjoy the life that was lived, not focus on how much trauma occurred at the end point.
Man, great perspective. And one of the things, as you were talking, what I find too is that a lot of times, for whatever reason, a family doesn't have that discussion, and it's not necessarily the most pleasant end of life situation for the loved ones. It often prompts another generation to do it better. So there's and hopefully, we're some of the less pleasant end of life situations are leading to that. Now, I always like to recognize when our audience members are asking questions, and it seems like there are a few medical aid and dying questions that are coming on board. Are both of you, would you be able to sort of share some perspective on medical aid and dying?
This is actually one of my areas of expertise. I published.
Oh, great. So
however I can help.
Let's start with this question from Jay Vitkus. As a person going through my last years of life, I would like you to address the outside possibility of medical assistance in dying for those that might consciously choose to terminate their life with dignity as a personal choice due to diminished quality of life. Rosie and Dr. Madison, feel free to share your perspective. And then there's another one that on this discussion thread as well.
I'm trying to see I'm trying to look.
Oh, sorry, it's in Q&A.
Where's the question in there? Like, what's the question that we're looking to get?
Oh, here, I'm going to drop it into chat.
Thank you.
Okay. And then, okay. And then I also want to make sure that I go over what both of your organizations do. I want to make sure we talk about that. But let's have a little chat about medical aid and dying.
Perfect. Why don't I just do a broad brush of this right now? So medical aid in dying first became legalized in Oregon in 1997. And so there's 10 other states, the Washington, D.C., who have this as a legal option right now. Just in 2024, there was 20 states that proposed legislation. So this continues to move forward in states even where this isn't a legal option yet. And most of these states that do have this have mirrored the statutes in Oregon, because what we have found is that there has not been a single substantiated case of coercion, abuse, or misuse of their policy. So what Oregon's Death with Dignity Act states is if you are an individual who has an adult 18 years or older, who has a terminal diagnosis with a prognosis of 6 months or less. So in a bit of context, that's the criteria for you to qualify for the services of hospice. You have to have mental capacity. So your physician has to believe that you have full capacity to make this decision. You have to make, again, some of this waxes and wanes with states, but usually it's 2 oral requests, 1 written request, two different providers have to contest that, yes, this person does have this diagnosis, has this prognosis, and we are confident that there's no coercion going on here, that this is truly what they want. Then this provider can write a prescription that they can access from their pharmacy, and then they can take that home and they can take it when they're ready. But they have to be able to self-administer. So they have to be able to, it usually comes in a powder form that they mix with liquid. They have to be able to take the glass and lift it to their mouth and be able to ingest the medications themselves. What we're seeing in states where this is an option is, people want this out of their fears of losing dignity, losing autonomy, not being able to do the things they once enjoyed, fear of pain. People who primarily use this have a diagnosis of cancer. They're living at home. They have the support of a hospice agency. Many of them are fairly educated. So we're finding that a majority have at least a bachelor's degree or higher. And the other interesting caveat is, again, when we look at, so we have like 27 years of data from Oregon, and we looked at all the times that people requested a prescription and got access to it, only 2/3 of them used it. So 1/3 of them never even used the prescription. So I think for many people, it's just knowing that if my disease gets too bad, if my quality of life is something that I just don't find acceptable anymore, I have this option here. And for some people, hospice and palliative is able to meet their needs and they're not needing to do that, right? But it's like kind of like having house insurance. You have this there just in case that you need it.
Yeah, it provides people with a choice if that's a choice that they want to have. Dr. Madison, any thoughts of medical aid in dying from your perspective?
I'm very supportive of the freedom to make these decisions. And I do agree with Rosie. I think she summarized it beautifully, but I think it is something that I see happening all over the country. So I think that we're making progress in this regard. And I think that it's again, we all want to live as long as we possibly can. But there is a caveat there, and that is, what is the quality of that life? And I think that for different people, they define it differently, but I think that for a lot of people, there does, unfortunately, only a small percentage of us, maybe 15-20%, have that quiet, peaceful, they die in their sleep at age 95. 80 to 85% of us have a much more protracted illness, typically, or illnesses that diminish our capabilities to the point where we might need long-term care, to the point where we no longer make decisions for ourselves. That then brings in that question of quality of life, and what do you want to do to prolong it? I think what Rosie highlighted there was that you have to be capable of making the decision to be potentially qualified for that. And so, but there are a number. That's, again, we're going back to why it's important to complete your advanced care planning documents and let your medical surrogates know what you would or wouldn't want. Not that it becomes a capability to do medical aid in dying under that circumstance, but it still is very helpful to have your medical surrogates understand what you would or wouldn't want done to prolong that life at that point in the event that you can't make those decisions.
Yeah, and I just want to jump in to be super clear to make sure everybody really heard what Dr. Madison was saying. You cannot access medical aid in dying if you do not have full capacity. We utilize a healthcare directive when somebody loses the capacity to make their decisions. So you wouldn't even put medical aid in dying in a healthcare directive. I just want to be very, very clear about that, because that can get confusing for some people sometimes, that it is so important to have these conversations. I mean, it can help lead up to that. I also want to address, Elva put in the chat that, yes, Oregon and Vermont are both states that you can travel to, and you don't have to be a resident of the state in order to access medical aid in dying there. Colorado has, they put some adjustments, tried to propose those this year, that Colorado might be a state. In Minnesota, it did pass this year, but we were also going to have that in our legislation, that you wouldn't have to be a state resident. So even states where that was what it was before, they're making amendments to those bills to try to expand that.
Wow. Okay. Great description. And I've heard this a few times, but Laura has a question that I've never heard on this topic, and I love it. She says, will any drugs taken for palliative care or aid for end of life prevent a donation of organs or the body? So, like if you did take the prescription, would that somehow void out being an organ donor?
Mike, do you want to take this one or do you want me to?
Go ahead, Rosie.
So I think the first piece to talk about when we're thinking about organ donation is many times people think of like heart, lungs, liver, pancreas. And really, it is very, very, very rare that somebody can be an organ donor like that. Usually what those circumstances look like is it's somebody young and healthy who maybe got in a car accident, was rushed to the hospital. Somebody like Dr. Madison might do an assessment and say, they don't have brain activity, then they're brought to the OR and that process is done. For a lot of my hospice patients where it was important to them to donate, I have been in awe sometimes of what has been able to be used. I recently worked with an individual and they said that their mom was able to donate to like 22 people. And it was like her skin, her eyes, her veins. I mean, I was just shocked at what they could use. When we're thinking like whole body donation, as far as like anatomical study, here we have the University of Minnesota where people can donate their body to research, or not to research, to science. So physicians like Dr. Madison have a cadaver that they can respectfully learn on. The only times I have seen my patients be rejected from that option is if they have some sort of disease that they're like COVID. They weren't taking anybody during COVID because we didn't understand it. I've seen if the body is super malnourished, just to the point where it's just they can't do what they need to do. But I've never seen it be disqualified because of a medication in my experience.
Okay, great. No, good, great question there. Now, Dixie shares that the medical aid in dying in DC law is critically limited, with only 2 participating physicians that will write the prescription and 1 pharmacy who will share the prescription. Thanks for sharing that, Dixie. I know this is viewed as a cutting edge, legislation, and it's just making this embraced by the medical system. But have you all seen similar situations in various states where it's maybe the law is passed, but it's not as accessible as we'd like it to be?
So what the data suggests when we look at these statistical reports, because all of these states have to acquire some data that we can able to pull from. And what we see there is that this is primarily exercised in urban areas. And I think part of that could be accessibility to providers that are willing to jump on board for this. Because that's the piece, is just because it's a legal option, we need to have both physicians. Some states allow nurse practitioners, and you also need to have mental health consultants if referrals are needed that are willing to jump on board and do this. So that has been an issue in some of these states, is just because it becomes legal doesn't mean it's easily accessible.
Man, yeah, but thanks for sharing that, Dixie. Okay, Catherine says, and this is an acronym, so I'm going to need some help on this. She says, your perspective on VSED, difficulty is the loss of capacity. VSED, and I'm going to do a quick Google search on what that is.
Voluntarily stopping eating and drinking.
Yeah. And I'm really glad that you brought this up, Catherine, because I was going to say that medical aid in dying is a prescription and and direction, whereas voluntary stopping eating and drinking, that's just basically what it states. But what's your perspective on that?
Go ahead, Rosie.
You know me, I can talk all day about this stuff. So what we've seen with VSED and what kind of how the conversation is moving now is people who, Steve, you talked about seeing this generational shift, right? People who saw their parents or someone that they love have a death that they're like, this isn't what I want. That pendulum is now swinging and they're saying, what can I do to avoid that? And so what I'm seeing from some of my clients and hearing is, if I start to get a dementia and it's advanced and I can no longer make decisions for myself, I don't want to be offered food and drink anymore. I want to hasten my dying process by not eating and not drinking. What the statistics tell us is that this is not painful. This is a peaceful passing. It can take weeks in order for death to come, but you are hearing more and more about this. What I will say, and I'm a clinician here in Minnesota, so I can only speak for kind of the statutes and the policies here in Minnesota, is I've never seen this done when somebody does not live at home. So if somebody lives in some sort of care center, whether it be a nursing home, a memory care, and assisted living, there's oftentimes statutes or policies where I've never seen it happen, and I hope that shift starts to come. But I think there's a lot of moral pieces for the caregivers there. But here in Minnesota, the patients that I've supported, the stories that I've heard from colleagues that I work alongside, is that this is really only happening when somebody lives at home and they have a very supportive caregiver that's a strong advocate that, again, has had these conversations with their loved one for a very long time about this.
Wow.
And I want to be clear too, if somebody says like, oh, I'm so thirsty, like this caregiver is going to be like, well, you're not, no, like that's not how this goes. Like they're listening to what the person is telling them, but understanding that this is what we're going to do to best employ this, because I know that that's what they want.
Man, this is great. Well, we're getting lots of questions that are coming in, and I want to just, don't worry, folks, we'll get to all this. I want to just pause real quick, and I want to make sure that we learn about both of your organizations and the roles that you play. Dr. Madison here, I'll bring up one of the roles is that you're with an organization called Thanacare. You want to tell us a little bit about this?
Sure. It is a digital platform for completion of advanced care planning documents. And so, again, it was through my experience with lack of preparation and the lack of the documents being available when they're needed that led me to pursue this. You know, at the time we started, now 4 years ago, there were still a lot of examples of paper documents, you know, that were either prepared by lawyers or even most of the healthcare systems in Minnesota were still using paper documents. And the problem with the paper documents were that they weren't always available when they were needed. And so this is a digital platform. It can all be done remotely on Zoom or Teams meetings, so you don't have to schedule an appointment. And we walk you through the process of completing the advanced care planning documents, including who's going to be your medical surrogate and what you would wish for at end of life. We ensure that it's available at the time when you need it. We give people a card and a QR code that it can be launched. It can be incorporated into the electronic health record. And then we make a little video wish, kind of once it's all completed, the individual, we record a video where they reaffirm essentially that these are the decisions that I've made, these are my wishes, and please honor my wishes at end of life. And the videos can be very helpful, you know, in that what I've saw repeatedly with paper documentation was that paper can be ignored. And so especially if there are members of the family that haven't been engaged in the conversations, which, you know, if the son from California who hasn't seen mom in a while flies in, you know, they can start to ask questions. And so the video basically of mom saying, well, these are the individuals who are going to make this decisions for me at end of life in the event that I can't, and these are my wishes, please honor my wishes. And that has proven to be very effective.
Wow.
So that's
what I love about
Thanacare is.
What I love about the platform, as I shared on the website there, is that it's, yes, you're utilizing digital technology, but you're working with real people. You're scheduling an appointment. So, and you're talking to somebody who's asking you questions. It's not like, you know, oh, go on your app and fill this out, because I think we've all been barraged by all of that. Like there's lots of websites and lots of, and it's difficult for some of us, you know, to be disciplined enough to fill that out, save the digital copy, send, you know, tell all of our families. So it's kind of like you guys are coaching people through this.
Definitely. That's a very important point, Steve. I mean, there are self-directed options to try to complete advanced care planning documents. I think that my experience is that there are There are families that have medical professionals in the family. You know, I mean, 15% of all workers are healthcare workers. So that there are examples where you have a medical professional that can help you get through those documents. But if you don't have that, it's really difficult for people to understand some of the complexity of some of these conversations. And so we do help people get through it. You can schedule an appointment with us online. Generally, the investment in time is 2 or 3 45-minute sessions. And so there is an investment of time to complete the process, but it is well worth it. I mean, and if you can do it when you're healthy, you know, and cognizant of what you want, that's the time to do it. It's not when you're going into the operating room.
Oh no, yeah.
That's not the time to do it. You know,
what a gift to your.
It is such a gift. It is such a gift to yourself and your family. I think if most people understood what they were doing by not doing this to their family. We've seen so many examples of sons and daughters who don't talk to each other after mom or dad died because of all the conflict that occurred. You know, so it's the right thing to do.
Okay. I've got some questions about Thanacare. We've got the other question thread that we're going to jump back on, but I want to make sure that we find out what Rosie is doing. And Rosie, here, I'll pull your website up. I love the name of your organization, A Better Ending. Tell us a little bit about what you do, and then we'll jump back on the question thread.
Absolutely. So a better ending really came about. I was working inpatient hospice palliative care during the pandemic. And I would be somebody that would be at the crossroads with people when we're deciding, do we continue to try curative care or treatment, or do we go a comfort focused care with hospice? And so I saw time and time again, hard deaths. I saw providers struggling to jump into the space to talk about end of life. And I saw families and patients really wanting to, but not having the language. And so I wanted to step out of this revolving door of reactivity. And I started my own company with the sole purpose and mission of helping people die better and helping people become more comfortable talking about and preparing for end of life. So I work in kind of two spaces. I work in professional development, working with all different members of the medical system and lawyers to better their advanced care planning process. And then I also work here in the Twin Cities. I have a caseload of clients that I work with, and I help them create really detailed and thorough healthcare directives. Because I have to tell you, just because you have a healthcare directive doesn't mean it's a good one. A mass majority of healthcare directives that I've seen drafted by attorneys do not do anything to help us in these crisis moments. I'm sure Dr. Madison can allude to that too. We need to be having detailed conversations and guidance so when we're at those forks in the road, we know what to do. And, you know, I am so proud to work alongside Thanacare, and, you know, I worked with them and multiple physicians to help them develop the primary healthcare directive that they utilize. And I'm unbelievably confident that if people go through that, whether it be a stroke, like the patients Dr. Madison sees, or something sudden, or even just the advancement of an illness, this document will provide the clarity that not only your medical team needs to help give appropriate recommendations, but also that your loved ones need, so that way they feel like they are honoring your decisions and not making your decisions.
Yeah.
Right? Because I've offered grief support for years. And one thing I hear over and over when we don't have that kind of direction, I had one daughter describe her grief experience as feeling haunted,
Yeah.
right? And so what I tell my clients is, if you love this is a sign of love. If you do this for your loved ones, this is one of the best gifts you can give them.
Man, this is great. Okay, let's get back to all these questions and let's tackle some of the ones about Thanacare. So first off, the one that's come up quite a few times is, how much does it cost to use the Thanacare services?
So the way that Thanacare works is that we have a bifurcated business model. So we basically lease or subscribe the software to caregivers like Rosie. We have relationships with social workers and death doulas and hospice and palliative care workers all over the country, where they use our software to facilitate their discussions. And the benefits of the software come with the software, of course. We also do the software plus service, where we have our healthcare professionals who we have relationships with help us and help our patients complete the documentation. And again, that's usually 2 or 3 sessions. The cost of that is $150.
Okay, all right. So it's very affordable if you go direct to Thanacare
It
for,
is.
you know,
And you can schedule an
this
appointment.
service. But
Yeah.
then it sounds like that that a hospice provider might use the Thanacare service, or another provider might use it, and they subscribe, and then they're giving it essentially like for their
Their
patients, it's
patients.
either
Yeah.
discounted or it's just free of charge.
Yeah, well, they pay us a monthly, a small monthly a subscription fee, and a small amount of money to enroll a patient on the platform. But
Okay.
I mean, our mission is to try to get as many people as possible complete their advanced care planning conversations ahead of time. That's our mission statement, and you know that $150 I quoted you, that's basically our cost. It
Mhm.
really is. I mean, that's the cost because our labor, you know, the people, the nurses, the social workers, the death doulas that we utilize to help us complete this process with our patients, we pay them to do that.
Got it. Now, question, does it include the MOLST and the PULSE, the medical, what is,
Providers orders for life-sustaining treatment.
yeah, yeah. Does it include that?
Yes.
Okay, great. And then let's see. Oh, yes. Okay, we had 2 questions about that. Yes, met here, and I'm going to drop most and post the what they're called into chat because I always forget it. But that's great that it's got that there. Okay, and then for providers, should I just give their contact information if they wanted to know how much it costs to
Yeah.
engage
Yep.
with you? Okay,
Yep.
so
They
for
can, there's a link
Michelle's
on our
question,
website. I mean, there's a link on our website to schedule an appointment with us. There's also for chat, there's a chat link that you can use to
okay,
ask us questions. But
okay,
and I
because
just wanted to also say, you know, Rosie and I and our efforts with Thanacare team and Rosie, you know, we're kind of linked emotionally in these in these conversations, and she has been a great resource for us, you know, to try to make sure that we have in our when we're trying to complete our efforts with this process of advanced care planning documents, that we're making sure that we're putting together a product that represents what it needs to be.
okay,
Thank you.
and let's see,
Steve, I saw a question in here that I want to make sure gets addressed.
yeah, jump on
I
it.
saw something about somebody's sister made a video for her end of life wishes and the state did not accept that. So my understanding in a majority of states, if not all of them, is that the video enhances the healthcare directive. It does not replace it. So you need to have the written document that is signed, and some states a notary is sufficient, some want notary and a witness, some 2 witnesses are efficient, but the video is not to take the place of that. It's meant to enhance it. And I'm so sorry that that is happening and that happened. It's so tough. And so I extend that support to you and just want everybody to hear that video enhances the document.
Okay, but you still need the document. Yeah.
Yes,
Okay.
yes.
And remember, folks, also the value of the video is for generations. You know, I mean, this is something that you know, hearing your grandmother's voice, or you know, and having them share that, it's lots of things can be thrown in there. And we learned about you know, sort of talking about the morals that you want to pass along to your family. I forgot what that was called, but you can combine some of these video documents too. Now, a question: does Thanacare operate nationwide so that documentation will be
Yes,
in all 50 states?
correct. All 50 states, and we follow the state guidelines in all 50 states for advanced care planning documentation.
Okay. Let's see. All right. Okay. Then Jay Vickus, specifically speaking as to medical aid in dying as a personal choice without a pending terminal illness, how is the individual accommodated? I understand that Switzerland offers this. So I'll drop this question into chat, but can either of you sort of comment on this question?
I am a mental health clinician by licensure. That's what a licensed independent clinical social worker is. We are the #1 mental health licensure in the United States right now. And so I come to this with holding both things in my hand at the same time. I very much advocate for medical aid in dying for my patients who are terminal. I've done so many suicide assessments. I created policies at hospice agencies around how they go about doing this. And it's very, very different, right? For somebody who it has a terminal condition and is very aware and very thoughtful and very informed about what's going on and is making a decision. I very much struggle with medical aid in dying outside of the terminal diagnosis. That is just my personal opinion. I have so many worries about our vulnerable population, about them not getting the support that they need. A terminal diagnosis, there isn't a fix. There's nothing we can do for that. There are treatments that we can do when people suffer from psychological and existential suffering. And so that is just my professional and personal insight into that.
Okay. A couple of things I dropped in to chat. Dixie was talking about one of her patients who terminated her life by fasting, and there's a video of that there that Washington Post covered that story. So if anybody's interested in that. Jeannie asks, can a person make a verbal change to their written directive? Does that negate the directive for the future? We might have some lawyers on here too, but what are your thoughts on that, a verbal change to an advance directive?
Go ahead.
I can just keep going. I get so excited.
I guess I would answer the question. People often confuse this as in a sense, it is a legal document, but it can be changed. It's not a binding legal document. I think that from my perspective, if you don't do it, then there's a problem because you haven't defined who's going to be your medical decision maker in the event that you're incapacitated. But you always have the right to change your mind about what's in the document. And so it's a very flexible thing. The purpose of having these conversations, really, from my perspective, the core purpose is to define who's going to make your decisions when you can't for yourself. And secondly, to give guidance to those medical decision makers who are, again, usually your family, and have that guidance be as detailed as possible so that they have guideposts that they can use when they get to the point of having to make those decisions. And I think the video process simply just reaffirms that. It makes it a little easier. So the video is not a binding thing, but it makes it easier for the family to accept the decisions that have been made if they can see mom or dad saying, please, this is what I want. And it makes it lifts the burden of saying no more care, because usually that's where we're at. That's where that we want to remove the burden at the end of life appropriately. When the decision is made, no more care, we want to remove the burden from the family so that they don't feel guilty about making those decisions. And only the patient can really help them do that.
Man.
I think it's important to notice too that if you're making verbal changes, we're not using your healthcare directive yet. A healthcare directive comes into place when you can no longer speak for yourself. So if you change your mind about something, you can, they're going to listen to you first and foremost. While I will say, you should be updating your healthcare directive every so often. This is not a one and done. I'm 37 and I recently just did my 3rd healthcare directive because things in life change. I learn more. My relationships have evolved. And so if you're looking and you're like, wow, this is a pretty significant change from what I have written here, do a new healthcare directive.
Now, this relates a little bit to what Paula is saying, and I love this. She says, quality of life is not apparent to us until we've been through a crisis and we see the difference between good quality and bad quality. And I tend to agree, Paula. I mean, when we're creating these documents and we're in an office or what have you, we might not have the perspective when we're standing over the bed of somebody who is receiving health treatment or in their end of life, and that can sort of change our opinion of how we would want to be cared for. Elva says, as Rosie said, the most whole body donation sites require a certain BMI, so that somebody can't be emaciated or morbidly obese.
Yep.
I'd never heard about that. I'm glad we had that line of questioning there. Okay, let's see. We've got there was a good one here that I wanted to bring up. Okay, so Linda asks, this is related to Thanacare. How does your service differ from the online and paper versions of the advanced medical directives? And she references agingwithdignity.org or the 5 Wishes product, that she's completed those and they're available online. Tell us a little bit about the difference between Thanacare and some of those other products.
So again, our mission is to get people to complete advanced care planning documents and to have these conversations ahead of time. We do not claim to be the only vendor who can help somebody complete mission. There are other products out there. I do have a bias against some of the products that are self-directed because, again, as I stated earlier, I just don't think most families have the medical sophistication to work through that. I think they do need help from a healthcare provider, but some of the paper documents are perfectly appropriate. Some of the other digital platforms available are perfectly appropriate. We do believe that it's important to make sure that the documents are available when they're needed, and that sometimes with paper documents that can be a little bit more difficult. And I think that what we're trying to do is to make our platform as all-encompassing as possible. So we're in the process now of putting it into 13 different languages. We're trying to include some of the conversations in and around diversity, equity, and inclusion, and we're trying to create the best product possible. But we will acknowledge there are other products available. We're trying to provide those products at a cost basis that people can afford, because we don't want affordability to be the reason why they don't. I don't think that, given how important all this is, I don't think that a couple $100, if that's what it is, if the spend is unreasonable. And I just want to dovetail on what Rosie said earlier. We follow up with our patient population, so we check in with them at least once a year just to make sure things haven't changed. And as that question was asked earlier about the quality of life doesn't become a concern until you have a medical emergency or a medical change in your status. That's all true. But I think if you go back and, if you ask most people when they're healthy, what do you want? Well, they would say, I'd like to live as long as I can, as long as I'm living a good quality of life. And what don't you want? Most of them would probably say, if I'm incapacitated and unable to make decisions for myself, and I find myself in an assisted living facility, I'm not sure that's a life that I would want prolonged unnecessarily. And again, there's complexity to that conversation, and I can't really get into every element of the complexity there, but there is a baseline understanding that people have about what kind of life they wouldn't want to have prolonged.
Elva's comment, again, going back to the medical aid in dying, she says, it's so annoying when the media and others refer to someone using medical aid in dying as suicide. It's a terminal illness that is killing them, not the medical aid in dying. That's very well stated, Elva. I know this is a confusing topic to a lot of folks too. Okay, I really want to make sure that we address this because one of our main topics of discussion on this platform is solo aging. We talk about a lot of solo aging challenges, solutions, and opportunities. And Jane says, what happens for a solo ager who don't have the supportive individuals to be their surrogates? Any insights on that?
So I've seen this a lot as a social worker. I just had a long conversation with a gentleman who's in this place just last week. One blessing about Minnesota is we have something called shared decision making. So what that means is when you haven't elected somebody, they look at what's in your support system. So for example, we've had a pharmacist sign a patient onto hospice before. We can have a doctor sign those forms if, again, this is within the best interest of the patient, right? And so Minnesota is more flexible than some other states in that way. Some states will require a court process, and you'll be appointed a guardian if you don't have somebody that's willing to step up in that space. Again, some states require it to be a next of kin. So that's something to think about, is if you have an estranged family, or you have somebody who would be your next of kin, a spouse's children, parent, however that goes for you, that you're like, no way would I want them to make those decisions. It's really important to have these documents. The gentleman I worked with last week, he really just couldn't think of anybody. So I said, well, then we need to make sure that the direction that we provide in here surrounding your values, your goals, and your wishes are abundantly crystal clear. So that way, if it gets to the point where you do need a guardian, you have this document that says, this is what I want. Because I've seen guardians more so err on the side of caution, just like our medical system does, of, really being like, okay, well, we should probably keep trying to treat, right? We should probably still keep trying to do this until you have a provider that's like, no, hospice 100%. So I think that's a way that solo agers can really protect themselves, is even if they don't have somebody that they're confident that could step up or will step up, is to make sure that the living will component of it is very, very detailed.
And what I like about what you've said, we've talked about this topic a bit on this platform, is create the documentation. Even like what I find a lot of times is folks will not create the legal documentation because they don't have somebody that they are willing to act as their surrogate. But I think the most important thing is that you have documented what you want your end of life wishes to be, and then if you're assigned a surrogate or guardian, it's clearly spelled out. But as you go along in life, you may stumble into somebody. We've seen people come together in like solo aging support groups that decide to help each other out in that regard. Let's see. I'm looking at the clock, and no surprise, we've burned through an hour, but let's kind of wrap some things up here. But there was another one here that I wanted to. A question for how long has Thanacare and a better ending? How long have your organizations been in operation?
For Thanacare, May of 2020.
Okay, and Rosie?
Mine was 2022, 2 years.
Excellent. Well, I mean, but you all as providers have been out there for decades providing service, but this is great. Okay. C. Donnelly was wondering, is there one place somebody could go from Washington State to go online or in person to find out about what all is available in their particular state? I'll ask you all this from the perspective of Washington State, but there might be somebody in Nebraska that's kind of wondering that. Where in general is the place to go in the state that you that you live in?
So I'm looking for, was there a specific resource?
Yeah, for
Sorry,
Washington.
I was typing at the same time.
Okay.
I mean, I will say when I've worked with, because of course I have people call me that work in other states, and I always want to be really cautious. I'm an expert about all things Minnesota. I mean, I legit have called hospice agencies. I've looked up, and because hospice agencies, like, they will connect you with their social worker. Sometimes they'll have, like, they call it like a care consultant, and sometimes those are social workers too. Obviously, when we're talking about resources, I'm going to be very biased because this is a social worker's wheelhouse, is stepping up in these spaces. I would think Compassion and Choices, they're really known as kind of an advocacy space for medical aid in dying, but they have a plethora of resources surrounding all things end of life planning. And when I'm really in a pickle, even as a social worker, I call 211. I call United Way, and they can be really, really helpful and guiding as well too.
No, this is great. Yeah, so folks, and I'm dropping in Compassion and Choices, their website there, and then I know Final Exit Network is another one that we've had some discussions on. So many resources. Well, I tell you, this was a great discussion. I am so glad that I was able to connect with you all, and I think what you're doing is so pioneering and innovative, and it just makes common sense, you know. I mean, so we'll definitely add links and contacts to the recording. We'll have all the chat there. But before we wrap up, anything that either one of you would like to share that you didn't have the opportunity to share?
Rosie?
Yeah, I mean, I think if anything, it would just be encouragement. You know, I know that your audience, Steve, is a mix of professionals and people who are in the community that are navigating these things. And I just want to say that this can be hard work. It's beautiful, it's complex, it's intimate, it's challenging, it's meaningful, right? And so it really jumping into this space, jumping into this planning, jumping into these conversations is really holding space for the both and that is life and death. And this can be really hard work, but it gets easier the more you do it. The more you talk about it, the more comfortable it gets. And ultimately, when we want to have a better ending to our life, we have to be engaging in these conversations, getting this education and planning for it so that way we can give that final gift to ourselves and also to the people that we love. That would be
Yeah,
it for me.
very well said, Rosie. And Dr. Madison, any closing notes?
No, I agree with Rosie. I mean, it's essentially moving beyond your discomfort, native discomfort about wanting to think about your death or plan for your death is a gift, as a gift to yourself, a gift to your family, and you will have a more peaceful, graceful death, and you will not expose your family to unnecessary angst and division and difficulty. I mean, it's just everybody wins. Everybody wins.
I love it. All right. Well, thank you too so much, and thanks to the community. It always blows my mind how great the questions and the resources and the sharing, especially when we talk about this topic. And so, don't worry, we'll have these two back on, and we'll keep on talking about end of life decisions. And I want to thank everybody so much for joining us today.
Thank you, Steve.
It was
Really.
an